Rice. I didn't ask him to go and get rice. No. Albert Sopra, call him for me. Ah.
Start.
We said an India. Another one said, oh, the highest choir.
Hello, madam.
Can we start?
Yes, madam.
Yes, madam.
Okay, so this evening we are going to talk about therapeutics. Please kindly mute your microphones. So we'll look at a few indications for use, drug resistance, and then we'll look at the various categories. This is a very broad topic. It comprises all the classes of anti-infective agents that we know of. And this is the most important group of medications, and it is the most commonly prescribed medications. And so we will spend quite a bit of time on them. So we'll look at the classes of drugs, their uses and the varying actions of the drugs, how the pharmacokinetics is. That is with regard to the absorption, distribution, metabolism, and excretion. Then we'll look at drug interactions and adverse reactions. So for each class of medication, we'll go through all of these. Now, before you decide on an appropriate antimicrobial drug to treat a specific infection, you need to consider a lot of things. For example, what microorganism are you even thinking about? So first of all, the microorganism must be isolated and identified. And this generally occurs through growing a culture. And then after the culture is grown, then the susceptibility of the organism must also be determined. So usually this takes about 48 hours. That's the earliest. And you don't want to wait for 48 hours. And that's where empirical therapy comes in. Please hold on. Hello, Mustafa. Good evening. Yes. Hi, good evening. Fine, thank you. Everybody is fine. Oh, I'm fine. I'm fine. Oh, I mean, that's normal. Yeah, I jog, so I'm okay. Yeah, I'm okay. No, I wasn't supposed to come today. No, you know, I wake up early because I do so many things in the morning. So it was business as usual. Yes, but I mean, I was able to sleep better. Yes, I was able to sleep better. Yes. Yes, please. 7 a.m. sharp. So right after I drop off the kids, I'll meet you at the court. Yeah. Don't worry, I'll run away. I'll come. You thought maybe I'll be having pains and I won't come. No. I'll come. Yes, exactly. Exactly. Oh, don't worry. I'm fine. Thank you. Okay, bye. Oh, sorry. That's my coach. So, so usually the culture and sensitivity, it takes about 48 hours. And like I was saying, that's where empirical therapy comes in, because you have to start something. The patient is suffering. The patient has an infection. You cannot say you're waiting for the culture and sensitivity results before you treat. So then you treat empirically. When the results come, then you reevaluate the patient, and then you might change antibiotics accordingly. So let me give an example. So maybe somebody has a UTI. You are treating with oral cefuroxime, for example. Then the patient brings the results and then is sensitive to the organism, maybe they isolated E. coli, sensitive to ciprofloxacin. Now, you didn't treat the patient with ciprofloxacin. However, you realize that the caution and sensitivity didn't also test against cefuroxime. That's the antibiotic that you prescribe. So you need to reevaluate the patient and decide whether is this patient getting better? Is this patient getting worse? Is this patient the same? Before you decide whether you change the antibiotics. There have been instances where you can decide that, okay, well, patient is getting better. So let me just continue on the cefuroxime because the lab did not test against cefuroxime. So I don't know whether this E. coli is resistant, but once a patient is getting better, to me, it's a sign that there's clinical improvement. Okay, so these are some of the small nuances that go with antibiotic treatment and prescription. So apart from the microorganism, you also need to look at the location of the infection. So is it a bone infection? Is it a soft tissue infection? Is it a brain infection? Is it a blood infection? Is it an infection in the eye? For the therapy to be effective, an adequate concentration of the antimicrobial must be delivered to the infection site. So, for example, if a patient has meningitis, which is a brain infection, there is no point prescribing an antibiotic that cannot cross the blood-brain barrier and get into the brain. And then, very importantly, especially in our setting, the cost of the drug must be considered as well, as its potential adverse effects, and also the possibility of patient allergies. So this is one important reason why when we are taking the drug history, we ask the patient whether they are allergic to any medications, because you don't want to give the patient a medication that they are allergic to. It's also important for us to take into cognizance the concept of drug resistance. Now, the usefulness of an antimicrobial drug is limited by the pathogens that may develop resistance to the drug's action. So if you are treating an infection, and the microorganisms that cause the infection have developed resistance to the antibiotics that they are using, it means the patient will not get better. And so resistance is defined as the ability of a microorganism to live and grow in the presence of an antimicrobial drug. So the drug is there all right, but the microbe is living, is thriving, is still causing havoc, still causing the infection. That is what we define as drug resistance. And when we take antimicrobial agents, they are either bacteriostatic or bactericidal. Bacteriostatic means that they inhibit the growth of the organism, and bactericidal means they kill the bacteria. And usually, resistance occurs when there's genetic mutation of the microorganism so that it is able to resist the action of the antimicrobial agent. And so usually what causes or what encourages resistance is the indiscriminate use of antimicrobial drugs. And what happens is that this indiscriminate use causes unnecessary exposure of the organisms to the drugs and encourages them to mutate or undergo genetic mutation so that they come up with resistant strains. And these strains, because they are resistant to the antibiotic that they are using, they will cause more damage than their predecessors who were susceptible to the antibiotic. So it is important that we reserve the use of antimicrobial drugs to infections caused by susceptible organisms. And also the dosage should be high enough to kill the microbe, and then should be for an appropriate period. So for example, you've been prescribed an antibiotic for 5 days, and then you decide to take it for 3 days. After 3 days, you feel better, then you stop. What will happen is that the microorganisms have not been completely eradicated. And because the dosages of the medications are not enough to completely eradicate them, they now survive and they develop resistance. Okay. And in this light, new antimicrobial drugs should be reserved for severely ill patients is serious infections, which do not respond to conventional drugs. Otherwise, if new antibiotics are used for common infections, then when the patients are seriously ill, these new antibiotics will not work because they've been exposed to the microorganisms, and the microorganisms have developed some resistance to them. So when you are in dire need of the efficacy of the antimicrobial, it would fail you. Okay, so let's look at antibiotics. So we've looked generally at antimicrobials, but now we are going to concentrate on antibiotics. For the next few lectures, we'll talk about antibiotics. There are various classes of antibiotics. Antibiotics are also known as antibacterial drugs, and they are drugs that inhibit and kill bacteria. And they are used to treat either systemic infections or local infections. So systemic infections are infections that involve the whole body, and local infections are infections that involve a part of the body. Let's say the eye is swollen or the leg is swollen. That is a localized infection. Systemic infection means it's affecting the whole body. Patient has fever, chills, and so on. So there are several classes of antibiotics. We have aminoglycosides, we have penicillins. So let me try and give examples of each. Aminoglycoside example is gentamicin. Penicillin is very common. Almost every corner you pass, somebody has used a penicillin before. You have cephalosporins, you have tetracyclines, you have lincomycin derivatives, you have macrolides, we have vancomycin, carbapenems, monobactams, fluoroquinolones, sulfonamides, nitrofuran, and so on. So let's look at aminoglycosides. So aminoglycosides are a class of antibiotics that provide effective bactericidal activity. So take note that aminoglycosides are bactericidal, means that they kill the bacteria, and their activity is mostly against gram-negative bacilli, some aerobic gram-positive bacteria, mycobacteria, and some protozoa. For you to be very good at prescriptions or very good at pharmacology, it means your microbiology should be spot on. Because if you don't know what a gram-negative organism is, or you don't know what organism is causing the infection that you're treating, then you're already lost from the beginning. So please, let's go back and revise our microbiology so that we'll be on point and we'll know some of these microorganisms, because once you know the antibiotic and you know the microorganism that is targeting, you'll be able to know also the infections that you are going to use the antibiotic to treat. So examples of aminoglycosides, we have amikacin, we have gentamicin. These are very, very common in our setting. Of the list that is provided, streptomycin is common too, but it's mostly used for TB, treatment of TB. If you go back to the previous slide, you realize that Mycobacterium is one of the organisms that aminoglycosides are effective against. And then tobramycin is also commonly used in Ghana. Tobramycin mainly comes in the form of eye drops. So these are the aminoglycosides that are common in our setting. It's important for us to understand some of the pharmacokinetics. Aminoglycosides are poorly absorbed from the GI, and so they are usually given parenterally. You won't find gentamicin as an oral medication. It's given either IV or IM. And the absorption is complete and rapid because you know that after parenteral administration, bioavailability is almost 100% for IM and it's 100% for IV. So they are distributed widely in extracellular fluid and they readily cross the placenta. Please, what this means is that once it crosses the placenta, it means that if the mother is pregnant and she takes this medication, it can cross the placenta to the fetus. However, it's very important for us to take note that aminoglycosides don't cross the blood-brain barrier. The clinical significance of this is that if you want to treat a CNS infection, aminoglycoside should not be your choice of antibiotics. Okay. Now, metabolism and excretion The aminoglycosides are not metabolized, so they are not changed, and they are excreted unchanged in the kidneys. So they don't undergo any chemical reaction in the body. They come out the way they are through the kidneys. And so they act as bactericidal drugs against susceptible organisms. And how do they do this? They bind to the 30S subunit of the ribosome in the bacteria. And this will disrupt the protein synthesis and cause the bacteria to die. Once no protein synthesis is occurring, the bacteria cannot carry out its metabolism and then it will die. Bacterial resistance can occur when the drug is unable to cross the cell membrane, or the drug is unable to bind to the ribosome, or it is destroyed by the enzymes of the bacteria. So before the aminoglycoside can bind to the ribosome, it has to cross the plasma cell membrane. So if it's unable to cross the cell membrane, then the bacteria can develop resistance to it. Or if it crosses the cell membrane but is unable to bind to the ribosomes as it should, if there's some alteration in the binding, that can also lead to bacterial resistance. Or the bacteria can produce enzymes which will destroy the antibiotic. And so this is what will lead to bacterial resistance. Some gram-positive enterococci resist aminoglycoside transport across the cell membrane. However, if you use the aminoglycoside with penicillin, what happens is that the penicillin will destroy the cell wall and allow the aminoglycoside to penetrate the bacterial cell wall. So a few pharmacotherapeutics, aminoglycosides are useful in treating, firstly, infections caused by gram-negative bacteria. Then they are also useful in serious hospital-acquired infections. So nosocomial infections like peritonitis, pneumonias, and they are very good for UTI. So it's important for us to take note. Infections of the central nervous system in collaboration with the penicillin. And then infections of the eye, where you treat with local instillation. If you'd remember, I said that aminoglycosides do not cross the blood-brain barrier, but if you give them together with penicillin, then the penicillin would facilitate the crossing and then it will be effective. So drug interactions, aminoglycosides are used in combination with penicillin to treat gram-positive organisms. And this increases the effectiveness of the medication, and especially if you give the aminoglycoside and penicillin together. Okay. Other drug interactions, amikacin, gentamicin, they cause neuromuscular blockade. So if you give them together with neuromuscular blockers, they will increase the neuromuscular blockade. You remember when we were talking about drug interaction, we talked about potentiation. So you have a neuromuscular blocker. You give the aminoglycoside in addition, it sort of potentiates the neuromuscular blocking activity of the medication, and it can lead to respiratory distress. Adverse reactions. So there are common adverse reactions that aminoglycosides are known for. We have peripheral nerve toxicity leading to the neuromuscular blockade. We have ototoxicity. So there can be hearing loss as a result of aminoglycoside use. We also have renal toxicity. Remember that aminoglycosides are excreted unchanged by the kidneys, and they can have an adverse effect on the kidneys. Adverse reactions to oral aminoglycosides. So let's say a patient has a condition and you give the aminoglycoside orally, it can cause nausea, vomiting, and diarrhea. The toxicity to the kidney may result in renal failure. And the toxicity to the neurologic system results in peripheral neuropathy with numbness and tingling of the extremities. And the risk of renal toxicity also increases when you give amikacin, gentamicin, or tobramycin with the following drugs: cyclosporin, amphotericin B, or acyclovir. I must say that it's difficult to keep all of these drug interactions in mind, and nobody is expecting you to do that. But it's very important that you have a BNF, British National Formulary. They have the adverse reactions at the back so that you can be checking from time to time. But the antibiotics that you prescribe commonly, you should at least be conversant with what their common adverse reactions are. So, for example, aminoglycosides are commonly known for their ototoxicity, the renal toxicity, and then the neuromuscular blockade. Just keep these things in mind. When we get to penicillin, you also understand some other adverse reactions. So the ototoxicity, that is the ear damage that is caused by the aminoglycoside, may be masked by antiemetic drugs. So drugs which are given for vomiting, if you give them in addition to aminoglycosides, you may not realize the ototoxicity. It doesn't mean it's not there. If you give them in addition to loop diuretics, it increases the risk of ototoxicity. So examples of loop diuretics are furosemide, or what we commonly call Lasix, given to enhance urination, especially in diabetic patients. And the hearing loss that occurs as a result of the ototoxicity may occur in varying degrees and may be irreversible. So we've talked generally about all the aminoglycosides, but the individual aminoglycosides may have their own particular usefulness. For example, we know that streptomycin is one of the antibacterial, anti-TB medications, sorry. And so it is part of the medications in the TB control program. Then we also know that amikacin, gentamicin, and tobramycin are particularly useful against gram-negative organisms. Examples are Acinetobacter, Citrobacter, Enterobacter, Klebsiella, Proteus, Providentia, Serratia, E. coli, and Pseudomonas aeruginosa. These microorganisms are commonly seen in urinary tract infections. And if you know your microbiology very well, you'd realize that the common thread in all these organisms is that they are all gram-negative enterobacteria, or they belong to the Enterobacteriaceae group. It's important to take note that they are inactive against anaerobic bacteria. So the bacteria that do not require oxygen, they do not work against them. So if there are no questions, we'll move to penicillin and then we'll have a discussion. Please, are there any questions? Hello?
Hello.
Yes.
Hello, Doc.
Yes.
Yeah, when you were talking about the lases, you said especially in diabetes. I don't know whether it's.
No, it's hypertensive. Sorry, hypertensive.
Yeah.
And then was a slip of
Right.
tongue. Sorry, hypertensive. Yes.
Okay.
All right. Any other questions? I don't know. Sometimes I feel I go a bit fast. Sorry about that. Please, do we all understand?
Yes, Doc.
Yes,
All right. So we can move on to penicillin. Okay. So, Nick,
Hello,
can
Doc.
you please make me the host so that I share my screen, or enable me to, whichever way. Can enable
allow
screen
to.
sharing.
Okay. So let me make you the host again, and then we can. All right, Doc, you are the host now.
Okay, so I can share the second one.
Yes, please.
Okay. So I didn't want it to be overwhelming. So I decided that today we'll just talk about the aminoglycosides and the penicillins. God willing, next week we'll finish up the rest of the antibiotics. Then we move to antifungals and so on and so forth. Right, sure. Okay. So we all know the penicillins, like they are the commonest group of antibiotics that are prescribed, and they are also very useful, and they have a wide spectrum of activity, and they are very useful, still very useful, even though they are the oldest group of antibiotics that were discovered. Actually, the first group of antibiotics that were discovered by Sir Alexander Fleming. Penicillins can be divided into 4 groups. So we have the natural penicillins, and these are penicillin G, potassium, procaine penicillin, penicillin potassium, penicillin V, and penicillin G, benzene penicillin, and what we call X-pen or crystalline penicillin. They are all part of the natural penicillins. And in 37 are the pediatric emergency units. Nick, can you become the host again?
Okay, Doc, you'd have to make me the host.
I have to make you the host again.
Yes, please.
Yes. So that it doesn't disrupt me. Okay, so that's
okay.
Fine.
All right, Doc.
Okay, so I was saying that in 37, our first line usually for treatment of several infections is crystalline penicillin and an aminoglycoside. So we usually do X-pen and gentamicin. Okay, so the second group of penicillins are the penicillinase resistant penicillins. And these are dicloxacin, nafcillin, and oxacillin. Another member of this group is flucloxacillin. I'm sure we are all very familiar with flucloxacillin. Then we have the aminopenicillins, and that is where amoxicillin and ampicillin are. Then we have the extended spectrum penicillins, carbapenicillin and ticagrelin. So after oral administration, the penicillins are absorbed mainly in the duodenum and upper jejunum of the small intestine. And the absorption depends on the type of penicillin that's used, the pH of the stomach and the intestine, and the presence of food in the GI. A lot of the time, you need an empty stomach for good absorption. So either you give it 1 hour before meals or 2 hours after a meal, hoping that the food would have emptied, left the stomach and be in the small intestine. But some penicillins can be given whether there's food or not. And examples of these are amoxicillin, penicillin V, and amoxicillin clavulanic acid. So what we commonly call amoxiclav. You can give it, yes.
Kevin, pinch me.
Sorry. So it's given, can also be given by.
I'm going to drink water.
Okay. Can also be given by IM, intramuscular injection. For example, if maybe the patient Sorry.
Okay.
So, so it can be given by an intramuscular injection, and a lot of the time the long-acting preparations are intolerant, and so they are given by IM. For example, the penicillin G. Okay. So they are widely distributed. You can find them when it's given. It goes everywhere. The lungs, the liver, the kidney, muscle, bone, and placenta. And high concentrations also appear in the urine. So it's also useful for treatment of urinary tract infection. The penicillins are metabolized. So compare that to aminoglycosides that are not metabolized. Penicillins are metabolized to some extent in the liver, and about 60% of it is excreted unchanged by the kidneys. However, naphthalene and oxacillin are excreted in the bile. So if you have any biliary issues, these can also sort them out. So penicillins are also bactericidal, just like aminoglycosides. And what they do is that they bind to several enzymes outside the bacterial cell wall and destroy them. And these enzymes outside the bacterial cell wall are called penicillin binding proteins. And these penicillin binding proteins are involved in cell wall synthesis and cell division. So once there is interference with cell wall synthesis and cell division by the binding of the penicillin, it leads to inhibition of cell wall synthesis and leads to destruction of the cell. And so they are very useful for gram-positive organisms mainly, but they also have some activity against gram-negative organisms and anaerobic organisms because they act on the cell wall. And we know that cell wall is peculiar to a lot of bacteria, both gram-positive and gram-negative. And so that explains the very wide spectrum of activity of the penicillins. So drug interactions, there's a medication called probenecid, which increases the plasma concentration of the penicillin. And then also, when you are taking penicillin with the methotrexate, it increases the risk of toxicity of the methotrexate because it reduces tubular secretion. Then also, tetracycline. If you are giving tetracycline in addition to the penicillin, it reduces the action of the penicillin. And neomycin decreases the absorption of penicillin B. And it's very, very important for you to take note of this, that the effectiveness of hormonal contraceptives is reduced when you are giving penicillin or ampicillin. So if you have a woman in her reproductive age who is on penicillin therapy and is also on a hormonal contraceptive, it might be important to advise them to use an alternative or a backup method of contraception so that they don't experience failure of the contraceptive method. Then also, penicillin has been known to increase the risk of bleeding when taken with an anticoagulant. So the patient is on an anticoagulant and maybe patient has a clotting problem, a clot somewhere, and it's on an anticoagulant. Maybe deep vein thrombosis, patient is on anticoagulant, patient is taking the anticoagulant. Then patient gets some infection, and then you put the patient on penicillin. It's important for you to note that this anticoagulant that the patient is on, adding on the penicillin would lead to an increased risk of bleeding. And so you have to be on the high lookout, and you have to actually caution the patient that if you see this and this and this sign of prolonged bleeding, please come to the hospital. On the other hand, you could change the medication, and instead of giving penicillin, give something else, which would not interact with the anticoagulant they are taking. Then high doses of penicillin can inactivate aminoglycosides. And so also you shouldn't mix the penicillin in the same IV that you are given with the aminoglycoside. So you may need to change the given set. If let's say you are giving the patient penicillin and aminoglycoside, you may need to change the given set. Now, for penicillins, hypersensitivity reactions are the major adverse reaction. You've heard of penicillin allergy, yes, that's a major anaphylactic reaction. You can also have serum sickness, whereby you have this reaction occurring 1 to 2 weeks after injection. You can have a drug fever. Patient is having high temperature is not settling. As soon as you stop the penicillin, temperature crashes. That's drug fever. Then you have various rashes. Penicillin is very, very notorious for causing rash. And when you give the oral penicillin, they can cause inflammation of the tongue, they can cause nausea and vomiting, and they can cause diarrhea. Okay, so I have about 2 minutes. Please, are there any questions? Questions. I
Madam,
don't know if
please,
I should.
No.
Pardon, yes, please go ahead.
Please, with regards to the contraceptive and then the penicillin, is it the entire class of penicillins or just a few of them that causes?
It's a group, it's a class. So let's say the patient is taking amoxiclav and is on the pill. That would be a good example.
Okay.
So this is why drug history is very important, because you may not even know that they are taking the pill. You see. So when you take a drug history, and when you are prescribing, you can decide that, okay, let me just avoid this group and just choose some other group. Any other question? All right.
Hello, madam.
Yes.
The issue concerning the, how do you call it, contraceptive, they will not tell you, some of them, especially the young ones who are not married. And they will tell you that, they are on contraceptive, but they are pregnant. So it can be because they have taken some of this. I was very happy when I heard it. Yeah, they will not tell you.
You are very happy. So because of that possibility, you should also have a high index of suspicion. In fact, one of my teachers always says that as for women in their reproductive age group, you should always do a pregnancy test every time before you even put them on medication, because they may not even know, or they will be lying, and you give a medication that is even harmful to the fetus. So, yeah, as a woman. Yeah. Any other question?
Madam,
Yes.
please. So I wanted to find out if a patient is on warfarin, let's say warfarin.
Yes.
And then the patient takes the penicillin. You are saying that there's a possibility that there can be excessive bleeding.
Yes.
Okay.
Yes, please. We have less than a minute.